Bismillahirrahmanirrahim. The topic for today is a very common disease, the gastroesophageal reflux disease, commonly known as GERD. And in today's talk, we will try to cover these following important aspects of this disease: its definition, its pathophysiology, clinical manifestations, how to evaluate a patient of GERD, then treatment and complications. GERD is a very common disease, but there is always difficulty in defining GERD. And two main definitions, they are accepted by the gastroenterologists and physicians. And the one is by the Montreal consensus panel. 44 experts in the field of GERD, they deliberated over a course of many years, number of meetings, and then they came up with their consensus statement and recommendations, which were presented in the World Congress of Gastroenterology 2006 in Vienna, and later on it was published in the American Journal of Gastroenterology. And this Montreal consensus statement defines GERD as a condition which develops when the reflux of stomach contents causes troublesome symptoms and or complications. So main component in this definition is the word troublesome. And what is meant by troublesome? It is the patient who is going to decide what is going to interfere with his lifestyle and what is going to interfere with his quality of the life. Another common accepted definition by the American College of Gastroenterology, and this defines GERD as symptoms or mucosal damage produced by abnormal reflux of gastric contents into the esophagus. So the reflux has to be abnormal or pathological, and according to this definition, sometimes we can see a patient at first time with complications without any symptoms, and this disease is often chronic and relapsing. One has to differentiate between the physiological and pathological reflux. The physiological reflux is common. It occurs when the lower esophageal sphincter opens in response to swelling or gastric distension. And this type of reflex, this physiological reflex, is postprandial. It is short-lived. It is not associated with symptoms, and patient is not having any nocturnal symptoms. On the other hand, the pathological reflex, which is abnormal reflex, is usually associated with symptoms. It can be associated with mucosal injury, and patient also have nocturnal symptoms. As far as the epidemiology is concerned, it is a very common disease. 20% of the overall adults, they have this manifestation of GERD, and about 44% of the adult populations, they will have the symptom of heartburn or regurgitation at least once a month, and 14% of the adults, they may have symptom every week, and in some 7% of the cases, the symptom may be there on daily basis. A very common disease, but most of the time the manifestations, they are just mild and recurrent symptoms, and majority of these patients, they don't consult any physician or general practitioners, and they will be just having symptomatic relief with on-the-counter available medicines. A small majority of the patients, they will have more frequent symptoms, and they usually consult the primary care physicians. Whereas, just like the tip of the iceberg, a small majority of the patients who have chronic symptoms or who presents with complications, they will be consulting the gastroenterologists. Coming to pathophysiology of this very common disease, 4 major physiological mechanisms they protect against the esophageal acid injury. Normally we have physiological reflex, the acid from the stomach entering into the esophagus, but this physiological reflex is not associated with any symptoms or mucosal injury, and 4 main mechanisms are responsible for this protection of esophagus from the acid injury. Number 1 is the rapid clearance of this reflex material from the esophagus, and it is mainly by 2 mechanisms. Number 1 is by the peristaltic movements, which will push the reflex material from the esophagus into the stomach, and second one is by the saliva, which is alkaline and it will neutralize any acid with its physiological alkaline activity. And normally 7 cc of the normal saliva is able to neutralize 1 cc of 0.1% sodium, this acid. So any mechanism which interferes with the peristaltic activity of the esophagus, anything which disturbs the salivary secretions, is going to interfere with this mechanism of esophageal protection. And similarly, the mucosal integrity itself is an important barrier to injury by the acid. So anything which interfere with the mucosa, like the use of NSAIDs or bisphosphonates, is going to make patient vulnerable for mucosal injury. The most important thing is the competence of the lower esophageal sphincter, and we will discuss in detail the mechanism of this barrier, which is the most important barrier against the reflux of acid contents from the stomach into the esophagus. And then the gastric emptying itself is also a protective mechanism, because it will decrease the intragastric pressure and the contents may not be able to regurgitate from the stomach into the esophagus. The lower esophageal sphincter is the most important barrier against the reflux of the gastric contents into the esophagus. And this barrier mechanism has 3 important components. Number 1 is the lower esophageal sphincter, which is a tonically contracted part of the distal esophagus, which maintains a tone of 10 to 35 mm of mercury. And because of this tonic contraction, it does not allow the opening of the lower part of the esophagus. It only opens in response to swallowing or in response to release of the gas from the stomach when it is distended. It is just a vent mechanism, and you have the transient relaxation of lower esophageal sphincters. But when these relaxations they become abnormal, then they may be associated with abnormal reflex. And sometime when the sphincter itself becomes hypotonic, then this may also be associated with abnormal reflex. The second component of this barrier is the position of the gastroesophageal junctions. It is located in the abdomen, and because of its angulation, it acts as a flap valve, and this mechanical mechanism, it also helps in reflux of the gastric contents from the stomach into the esophagus. And third component of this barrier is provided by the diaphragm. The crural component of the diaphragm, it provides additional support to this barrier. So this gastroesophageal junction is the most important barrier against the reflux of the gastric content into the esophagus, and it has 3 components: the sphincter itself, the intra-abdominal position of the gastroesophageal junctions, and then additional support from the crura of the diaphragm. So as we discuss, the primary barrier to gastroesophageal reflux is the lower esophageal sphincters, and normally this sphincter, it works in conjunction with the diaphragm. So anything which will disrupt this barrier, then acid goes from the stomach to the esophagus, and this will produce the reflux disease. A number of mechanisms and factors, they are involved in the pathophysiology of GERD, and this diagram is showing number of these mechanisms. Number one, as I said, the impairment of esophageal clearance by the abnormal peristalsis or decreased peristalsis. And the common conditions which are associated with this abnormality, they include scleroderma, the esophageal motility disorders, and diffuse esophageal space. Then the saliva itself, it helps to neutralize any acid which is entering from the stomach into the esophagus, and impaired salivary functions is also one important contributing factors. The patients with the Zika syndrome, the Sjogren syndrome, and patients who are using anticholinergic drugs which interfere with secretion of these salivary glands, they contribute toward GERDs through this mechanism. Then impaired esophageal mucosal defense, the integrity of the mucosa when it is destroyed by the use of drugs, steroids, non-steroids, or bisphosphonates, is also another contributing factors. Then one important factor is hiatus hernia. We will discuss in detail the mechanism how this hiatus hernia contributes in the pathophysiology of GERD, and this is perhaps one of the most common mechanism, one of the most common association with GERD. And then transient inappropriate relaxation of the lower esophageal sphincters. Normally those esophageal sphincter relaxes in response to gastric distension, but once these transient relaxations they become abnormal and inappropriate, then they are associated with the reflux. Then gastric acid itself, the most important damaging factor in the reflux from the stomach into the esophagus is the presence of acid. And whenever the intraesophageal pH drops less than 4, this is going to cause severe damage to the mucosal epithelium. In addition to acid, sometimes the presence of the bicarbonates from the pancreas or the reflux of the bile from the duodenum because of the incompetency of the pyloric sphincter will also be contributing towards this reflex injury. Then the reduced resting pressure of the lower esophageal sphincters. Most of the time the sphincter has normal tone, but in some of the conditions when the sphincter becomes hypertonic and its pressure decreases less than 10 millimeter of mercury, then itself it contributes towards reflux of the stomach contents into the esophagus. Delayed gastric emptying because of the gastroparesis or because of pyloric obstructions, it also contributes because this will maintain the intragastric pressure for a longer time, and this will facilitate the reflux of the gastric contents from the stomach into the esophagus. And similarly, those foods which have slow emptying from the stomach, like the fried foods, the oily foods, they also contribute in the overall severity of the GERD. And then last, the pyloric competence, because it will allow the reflux of the bile and the pancreatic secretions, and this in addition to acid will be contributing towards the damaging property of the reflux. So number of mechanisms they are involved in the overall pathology of the GERD. Hiatus hernia, which is perhaps the most common association of the GERD, and this occurs when a part of the stomach is pulled upward through the hiatus and it enters into the thorax. So the movement of a part of the stomach above the diaphragm into the thorax and the movement of the gastroesophageal junction above the diaphragm is the mechanism for producing hiatus hernia. It may be a sliding type of hiatus hernia, it may be the paraesophageal, and this is the most common associations. About 1/4 of the patients with the non-esophagitis type of the reflux, they have associated hiatus hernia. About 3/4 of the patients who have severe esophagitis, they have underlying hiatus hernia, and 90% of the cases of the Barrett esophagitis, they have associated hiatus hernia. And obviously, when the stomach is pulled upwards into the thorax, the gastroesophageal barrier is then interrupted. The angulation, which normally acts as a flap valve, is lost. The tone of the esophageal sphincter is also decreased. And number 3, the additional support of the crura of the diaphragm is also lost. And this is how the endoscopic view of the hiatus hernia. You can see a part of the stomach protruding through the hiatus and seen in the lower part of the esophagus. Coming to the clinical manifestations and symptom of GERD, we can, for our convenience, divide these clinical manifestations into 2 broad categories: the esophageal and extraesophageal. The esophageal manifestations, they commonly include heartburn and regurgitation. These are the 2 most common clinical manifestations. But in addition, the patient can also have belching, dyspepsia, and sometimes as a complications, these patients, they can also present with adenophagia and dysphagia. And as far as the extraesophageal manifestations are concerned, it is important to always consider in the differential diagnosis when the patient has unexplained cough. Similarly, the patients, they can also present with wheezing and a full-blown picture of asthma. They can present with laryngeal symptoms of hoarseness, and sometimes these patients, they can present with features of sore throat, pharyngitis, a globus sensations in the throat, epigastric pain, and one very important manifestations may be atypical chest pain, the non-cardiac chest pain, especially when the injury and inflammation in the esophagus leads to its spasm. And interestingly, this spasm is also relieved by the nitrates. So sometimes it is real confusion whether we are dealing patient of ischemic heart disease or it is the underlying GERD which is causing the chest pain. Just about the heartburn, which is the most common manifestations, patient feels a burning sensations behind the epigastrium, which is usually postprandial or when patient is lying down, and usually it is nocturnal. And this table shows the overall frequency of the various symptoms which we encountered in patient of GERD. The commonest one is heartburn, which is seen in 80% of the cases. Regurgitation, which is effortless movement of the food from the stomach into the esophagus, is seen in more than 50% of the patients. And then you can have the other less common symptoms: abdominal pain, cough, dysphagia, hoarseness, belching, aspiration, wheezing, and globus. And the Montreal consensus statement classified the clinical manifestations of esophagus into 2 main syndromes: the esophageal syndromes and the extraesophageal syndromes. The esophageal syndromes were further subclassified into symptomatic syndromes and the syndromes with esophagitis. The symptomatic syndromes, they include the typical reflex syndromes with regurgitation and heartburn, and then you can have the syndrome of non-cardiac chest pain. And the syndrome of esophageal injury, they include reflex esophagitis with reflex stricture formation, Barrett esophagitis, and in the late stages even adenocarcinoma. And the extraesophageal syndromes, they again can be divided into 2 broad categories. Number 1, those manifestations which have got a clear-cut association with GERD, and they include number 1, cough, then laryngeal symptoms like hoarseness, asthma, and dental erosions. And those syndromes which are not clear-cut associated with the GERD, and they include the pharyngitis, idiopathic pulmonary fibrosis, sinusitis, and similarly some other non-specific manifestations. So factors that can aggravate GERD, they include, most important one is diet. Already you have GERD, and these dietary factors, they will aggravate the symptoms and clinical manifestation of GERD. And the main diets which can aggravate the symptoms, they include the diets which contain caffeine, fatty and spicy foods, chocolates, coffee, various types of mints, citrus fruits, and alcohol. Then the position and activity like bending and straining, because they will increase the intra-abdominal and intragastric pressure, and they will facilitate the gastric contents regurgitating back into the esophagus. And similarly, the external pressure, which is seen during pregnancy with tight clothing around the abdomen or during obesity. So these are the factors which will be aggravating the symptoms of underlying reflux. And these are the diagrams which show the association of various factors: the diet, then eating in hurry, patient is driving and he is in hurry to reach his office, and he is taking his lunch or his breakfast while driving. And similarly, various types of food: fried foods, spicy foods, oily foods, chocolates, cakes, all these are contributing towards the symptoms of GERD. And similarly, a number of drugs, they can also encourage the reflux, or they can aggravate the symptoms by a number of mechanisms. And the main categories of drugs which are associated with the GERD manifestations or its aggravation, they include the smooth muscle relaxants like nitrates, the calcium channel blockers, and phosphodiesterase inhibitors like sildenafil and its drug of this same category. Then antimuscarinic drugs like the anticholinergics, the tricyclic antidepressants, and various antihistamines. Then sedatives, alpha adrenergic receptor blockers, beta blockers, the theophylline compounds, the bisphosphonates, and NSAIDs. The use of bisphosphonates is very common in the elderly person. They are mainly used for the underlying problem osteoporosis. And one precaution which should always be taken when administering these drugs, they should be always taken empty stomach in the morning with large amount of water, and patient should not be lying down at least 1 hour after intake of these drugs. So these measures, taking them empty stomach with large of water and then patient not reclining for 1 hour, will minimize the esophageal injury which is associated with the use of bisphosphonates. Then coming to diagnostic evaluations, it is very important to understand that if the classical symptoms of heartburn and regurgitation, they exist in the absence of any alarm symptoms, then diagnosis of GERD can be made on clinical grounds, and patient can be started on empirical treatment, and there is no need for any diagnostic workup. So it is very important that every patient who is presenting with just the typical symptom of GERD should not be subjected to any diagnostic evaluations, and especially the endoscopy, which is most commonly done in this patient, is not needed in most of the patients. And what are the alarm symptoms? Because when they are present, then the patient may need investigations, and these alarm symptoms, they include adenophagia when there is painful swallowing, or dysphagia when there is difficulty in swallowing, the early satiety, GI bleeding, vomiting, waist loss, or when patient presents with iron deficiency anemia. So when to perform the diagnostic test, and these are 5-6 settings where you can subject these patients to diagnostic evaluations. Number 1, when the diagnosis is uncertain. Number 2, when patient presents with atypical symptoms. Number 3, when the symptoms are associated with complications like dysphagia, which indicates that patient might have developed some stricture. Our patient is showing inadequate response to therapy. Our patient have recurrent symptoms and patient is not properly responding to your medications. Or if you have planned a surgery for these patients, then prior to anti-reflux surgery, these patients should also be subjected to these investigations. And there are three sets of investigations which we can do in these patients. Number one, those investigations which will document the underlying mucosal injury. Number two, those investigations which will document and quantify the reflux. They will, number one, confirm the presence of reflux, and number two, they will also help in quantification of this reflux. And number three, to define the underlying pathophysiology. Those investigations like manometry, which will define the abnormality in the peristaltic movements or other abnormalities in motor activity of the esophagus. So those investigations which help in the documentation of mucosal injury, they include barium swallow, the endoscopy, and mucosal biopsy. The barium swallow is usually the first diagnostic test, and especially when the patient is presenting with dysphagia. And the barium swallow can demonstrate the presence of stricture, its location in length. It can also indicate the presence of any mass lesions, its exact location and its length, and it can also demonstrate the presence of the underlying hiatus hernia, what its size and what its type. But this barium swallow has got its own limitations, and it is not possible to have detailed mucosal examination for erosive esophagitis or for the Barrett esophagitis with the help of barium swallow. The main investigation to demonstrate the underlying mucosal injury is the upper endoscopy, and the main indication to carry out the endoscopy are when patient presents with alarm symptoms, patient is not responding to empirical treatment, or you want to have the preoperative assessment of the patients, or in the detection and in the monitoring of the patients for Barrett esophagitis. So the upper GI endoscopy is very helpful in demonstrating the mucosal injury. But very important thing to remember, the absence of endoscopic feature, it does not exclude the diagnosis of GERD, because 30 to 50% of the patients with clear-cut clinical manifestation of GERD, they won't show any mucosal injury on the endoscopy. So this category of the patient is labeled as NERD, N-E-R-D, and NERD means either negative endoscopy reflex disease or non-erosive reflex disease. So 30 to 50% of the patients, they won't show any evidence of mucosal injury on the endoscopy, although they have typical symptom of the GERD disease. So this is a strong message for the primary care physicians, for the gastroenterologists who are faced with the need to make a clinical diagnosis and to minimize the expensive investigation. So every patient of the GERD is not needing endoscopy, and moreover endoscopy in 50% of the cases may not be demonstrating any underlying mucosal injury. The second set of investigations where we want to confirm the presence of the reflux and we want to quantify the amount of reflux is the 24-hour pH monitoring, which is physiological studies. And this is a accepted standard for establishing or excluding the presence of GERD for those patients who are not showing any mucosal evidence of injury on endoscopy. And two types of investigations they are possible. One is the transnasal, which is the old routine of estimating the 24 hours pH monitoring, a transnasal catheter is pushed, and then the pH is recorded for 24 hours, and the percentage of time in 24 hours where the intraesophageal pH drops less than 4 is estimated, and then we have a scoring system on which we score the severity of this reflux, and then we can also correlate it with the symptoms. The new techniques is a wireless capsule which is ingested, and then it is transmitting its information which is recorded about the pH, and we can record for about 48 hours. This is more convenient for the patients, and it is less troublesome, and patient can carry out his routine daily activities and also his daily food intake, and we can record the overall pH in the 48 hours. And this is how the record is made, and the maximum time for which the pH drops less than 4 is indicative of the reflux. And in this diagram you can show that during the night hours between the 11 to 2, the patient shows a drop in pH below the baseline of 4 as compared to the normal person, indicating a clear amount of reflux, because most of the reflux occurs and acidification occurs during the night, so most of the patients they suffer from nocturnal symptoms. And sometimes when you have to demonstrate the exact position of the lower esophageal sphincters, then we have to go for the esophageal manometry, which has a limited place in the overall investigation of the GERD, and it will assess the peristalsis, which is essential before we undergo the anti-reflux surgery, and this also helps to exactly localize the position of lower esophageal sphincter for the placement of the pH monitoring capsule. So coming to treatment, the main goals of treatment in a patient of GERD, they include symptomatic relief, healing of esophagitis, prevention and treatment of complications, and then maintaining the remission. One most important aspect of the management is the lifestyle modifications, and these patients should always be advised to carry out these lifestyle adjustment and changes in addition to their medications. And the main components of the lifestyle changes, they include weight loss if the patient is obese and overweight, because obesity itself is contributing towards GERD. It is an independent risk factor for the development of the Barrett's esophagitis. Then if the patient presents with nocturnal symptoms, we can have elevation of the head of the bed in selected patient for 6 to 8 inches. And remember, it should be the elevation of the esophagus, not the neck. So head end of the bed should be elevated by placing the blocks under the legs and not just keeping 2 or 3 pillows. Then patient should be encouraged to eat small and frequent meals. Patient should also reduce the total amount of the fat in the form of margarine, butter, oils, salad dressings, gravy, fatty meats, full fat dairy or milk products, and cheese. So intake of these foods, they should be reduced or minimized. The other components of lifestyle changes, they include to maintain an upright posture while eating and for 45 to 60 minutes afterwards. Then patient should also avoid food 2 to 3 hours before going to the bed. So the dinner should be taken at least 2 to 3 hours before retiring. Patient should also avoid tight clothing in the abdominal area. If the patient is a smoker, he should stop smoking, and patients should also be avoiding in ingesting large quantities of the fluids with the meals, because they will increase the intragastric pressure and they will facilitate in the process of reflux. As far as the dietary advice in a patient of GERD is concerned, the main recommendation are that the routine, these patients should avoid those foods which aggravate or which trigger the reflux, and the list includes the excessive use of chocolates, the caffeine which is present in the regular coffee or regular tea. Patients should also avoid alcohol, citrus fruits and their juices, the mints like peppermint and spearmints. The tomato products should also be avoided, and patients should also be avoiding intake of large spicy foods, garlic and onions, and especially the use of these soft drinks, the carbonated beverages. The medical options which are available, they include the use of antacid and alginate, the H2 receptor antagonist, the proton pump inhibitors, and the prokinetic agents. The antacids, now they are used very less often. They provide a very short but a quick relief, and they act by physiologically neutralizing the acid because they contain alkali. And about 1/3 of the patients who are having heartburn symptoms, they will be using this antacid at least twice weekly, and they definitely have more efficacy as compared to the placebo. The H2 receptor antagonists, which were at one time mainstay of treatment, now they have been replaced by the PPIs. They are definitely better as compared to the placebo and to the antacids, and they can sometimes be used for the quick relief. And the relative doses of the 4 available H2 receptor antagonists is shown, and they are now used very less often. Similarly, the prokinetic agents, they are not commonly used, and they have limited role in the overall management of patient with GERD. The mainstay of treatment is the use of proton pump inhibitors. They are much better as compared to the H2 receptor antagonist, both for the overall efficacy and the speed of relief. So they provide a faster relief, and they provide a more effective control of the symptoms. And the main agents which are available, total 6 agents, they include omeprazole and esomeprazole, then lansoprazole and dexlansoprazole, pantoprazole and aripiprazole, and in the equivalent doses they are all equally effective. So in comparison, the PPIs, they show a much faster rate of healing and more effective healing as compared to the H2 receptor blockers. And as far as the comparison of various modalities used for the management of GERD is concerned, the lifestyle modification response will be seen in 20% of the cases, with H2 receptor blockers in 50% of the cases, single dose of PPI in 80%, and with increased dose you can have the control of symptoms in 100% of the cases. And the main risk factors for failure or partial relief, they include those patients who have a longer duration of disease, or if the patient has got underlying hiatus hernia, those patients who have extraesophageal symptoms, or patient has a poor compliance, or we are using the suboptimal doses of these drugs. So these factors should always be considered whenever the patient is showing no response or incomplete response. And for those patients who are showing partial response to once daily regimes, we can tailor-made the treatment regime by switching over to some other proton pump inhibitors, because sometimes the second brand will be showing more efficacy, or we have to adjust the timing of the dose, and the most appropriate time for intake of proton pump inhibitors is before the first meal of the day, because then they will show the maximum inhibition of the protons. So normally they should be taken half to 1 hour before the breakfast, and sometimes we have to switch over to daily dosing in those patients who have predominant nocturnal symptoms, or patients who have variable schedule of their eating, or patients who have a sleep disturbance. Because sometimes these PPIs, they have to be used for a very long time, and sometimes the whole life of the patients. So the long-term use can be associated with number of risks. They can interfere with the absorptions of vitamins and minerals, especially the absorption of B12 is affected, the absorption of calcium is affected, the iron is affected, and the acid, because it is one very important defense mechanism. So suppression of acid for a long time will be associated with increased incidence of community-acquired pneumonias and diarrhea because of the Clostridium difficile. The same type of the pumps, they are present in the osteoclasts. So prolonged use of these PPIs is associated with risk of osteoporosis and hip fractures. There is theoretical risk of interaction with the clopidogrel, because clopidogrel is a prodrug and it requires its activation by the enzyme of cytochrome P450, and same enzymes are inhibited by the omeprazole. So rabeprazole and pantoprazole, they are relatively safer drugs when you are having this type of interference or interactions. And obviously prolonged suppression of acid will produce rebound hypergastronemias, and this can be associated with gastric carcinoids. And when the patient shows a failure to the medical management, or patient prefers to undergo surgery as compared to the lifelong medical interventions, our patient has developed the various GERD complications, our patient is showing a large hiatus hernia and its associated complications, our patient is showing the atypical symptoms which are documented to be associated with reflux after 24-hour pH monitoring, then we consider the surgery. And the main is the fundoplications, whether this is partial or this is complete. And even after surgical interventions, 10% of the patients, they will have dysphagia for the solid foods, 2 to 3% of the patients, they can have permanent symptoms, and 7 to 10% of the patients, they can have symptoms of gas, bloating, dyspepsia, diarrhea, early vomiting, or early satiety. And the new modality of treatment is the endoscopic treatment, which is relatively new, and still it has got no clear-cut indications, and we have to select a well-informed patient who is having a well-documented GERD and who is showing response to PPI treatment. And 3 types of options are available. Either we subject these patients to radio frequency applications to increase the tone of the lower esophageal sphincter. We can use the endoscopic swing devices, or we can inject some material into the lower esophageal areas to increase its tone and its compliance. And this new technique was approved by the FDA in 2012, and this is the LINIX reflux system sphincter augmentations, a mechanical device which is put through laparoscopic and artificial sphincters consisting of the platinum beads which are wrapped on a magnetic core, and this is found to be very effective in refractory patients of the GERD. So various complications which these patients they can develop, they include the erosive esophagitis, they can develop fibrous strictures, and there is always risk of developing Barrett esophagitis, and then some risk of developing adenocarcinoma on the background of Barrett esophagitis. The erosive esophagitis, this is seen in about 40 to 60% of the patients, and remember, the severity of symptoms, it often fails to match with the severity of the erosive esophagitis. And endoscopically we evaluate these patients, and then we use the Los Angeles system of classification to classify the severity of the underlying erosive esophagitis. The healing of this reflux esophagitis can lead to formation of fibrous stricture, which will then be manifesting in the form of dysphagia. But remember, dysphagia in a patient of GERD is not always because of stricture. Sometimes the severe inflammation and mucosal edema associated with erosive esophagitis itself can be associated with dysphagia, and sometimes the abnormal peristalsis secondary to inflammations may also be contributing towards dysphagia. But whenever you come across dysphagia, always try to rule out the presence of underlying stricture. And this is how this stricture looks like on barium swallow and on endoscopy, and we can always try dilatation with mnemonic dilators to dilate these strictures, and sometimes it is successful. One of the most important complications is the development of the Barrett's esophagitis, and this is basically a metaplasia where the squamous epithelium of the esophagus is replaced by the columnar epithelium, and three types of metaplasia can be there. The replacement may be with the gastric cardiac type of epithelium, gastric fundic type of epithelium, and specialized intestinal metaplasia. And this metaplasia is associated with development of dysplasia, and especially the metaplasia with specialized intestinal type of epithelium is vulnerable to develop into dysplasia, and this can be then associated with development of adenocarcinoma. And this is how this Barrett esophagitis looks like. Normally the squamous epithelium of the esophagus, its whites are pinkish, but if the orange or red, the gastric epithelium is seen protruding into the lower part of the esophagus more than 1 centimeter in a linear or circumferential fashion, then we will label it as Barrett esophagitis, and it is confirmed after taking the biopsies when you will have replacement of squamous epithelium with the columnar epithelium. The esophagitis, Barrett esophagitis, is treated with the same manner as reflux esophagitis with relatively larger doses of the proton pump inhibitors. They will not completely cure the Barrett esophagitis, but the long-term use of these acid suppressant drugs is helpful in preventing the development of dysplasia and adenocarcinoma. And these patients, they should be subjected to the follow-up. Those patients who are not showing any dysplasia, the endoscopy can be carried out every 3 to 5 years, and if the patient shows any evidence of dysplasia, then this endoscopy should be carried out every 1 year or more frequently. And the most dreadful complication is the development of esophageal cancer, which usually occurs on the background of the Barrett esophagitis. The risk of getting adenocarcinoma is 0.2 to 0.5%, and overall there is 11% increase risk of developing adenocarcinoma when the patient has got underlying Barrett esophagitis. So in this lecture we have tried to cover these important aspects of a very common entity, GERD, and thank you very much.